And we'll move forward to the next topic, that's localizing the lesions made simple, to be taken up by Dr. S. Ambika. Dr. S. Ambika is a consultant and the head of the Department of Oculoplasty at Shankar Nethralaya, Chennai. Of neuro-ophthalmology. Actually, this topic, localizing the lesions made simple, actually doesn't speak of any subspecialty. So I'm sorry about that. Apologies. She's the HOD of neuro-ophthalmology at the Shankar Nethralaya, Chennai. Over to you, Dr. Ambika.
I can use this. Okay, good afternoon, all of you. First of all, let me thank the organizers for this opportunity. Well, I am a neuro-ophthalmologist. Let me just make it clear. And I can make two disclosures. I don't have any financial disclosures to make, and I will stick to my time. And I know it's lunchtime, so we will try to make it as interactive as possible. I'm going to talk on localizing lesions made simple. And I'm missing my previous speaker who should have given an overview of optic neuropathies. So let me make as relevant to my talk the missing talk. See, localizing a lesion will always start with you talking to a patient. So neuro-ophthalmology is nothing but first start with a proper history taking. You don't have to think on MRI or CT or anything, and don't think about hi-fi investigations without talking to your patient. The most common complaint what you would encounter in neuro-ophthalmology clinic is vision loss. So vision loss can be of a bizarre nature, right from a refractive error to a brain tumor. So you have to know how your patient is going to start giving the complaints to you. A vision loss and followed by diplopia. And this is the conventional diagram which we all have seen in our med school. And I'm not going to talk theory as much as possible. It's up to you to read up that. And here you have to apply how your theory to clinic is the key what you have to take home. So we will try to make it as much possible as case-based. So this is the visual system which I am trying to separate this entire talk into 4 parts. I'm going to talk on the optic nerve and the disorders, the chiasm and the retrochiasm and the higher cortical dysfunction. So this is how we are going to decode the vision loss now. So let me go on stepwise and case-wise. So optic neuropathies, like if at all you're going to get a patient with a vision loss, first of all ask what nature of vision loss. Is it an acute? If it's acute, if it's painful or painless. If it is a gradual, is it a painless gradual drop in vision? Because this all is going to give a clue for what type of etiology you're going to see behind that optic nerve. Because at the end, you're going to end up seeing a pale disc and you don't know what is going to cause that. So you have to give the prognosis based on the way you elicit the history from the patient. So all optic neuropathies is going to have a dyschromatopsia. Apart from the vision loss, you also have associated features like squint, proptosis, redness, ICP signs. All those things have to be used cumulatively. So pupillary reaction is the key. So let me just get anybody telling what are the optic nerve function tests? Already I've told 2. Yeah, make it interactive. We all will doze off. It's neuro-ophthalmology. Pupillary function, yes. How brisk a pupil is. If it is going to be a bilateral dysfunction, you will see a sluggishly reacting pupil. Don't expect a relative afferent defect in a bilateral optic pathway lesion. If it is going to be bilateral, if it is asymmetric or a monocular optic pathway dysfunction, you can expect a relative afferent defect. And there's one more condition where you can't expect a relative afferent defect. When? When the visual pathway is involved in a retrochiasmal lesion. When the LGB, your pupil fibers have gone apart. So beyond a LGB lesion, if you're going to suspect a causative agent, you may not end up seeing a relative afferent defect. So the visual field loss, the optic nerve function test includes optic nerve vision, color vision, pupillary examination, and a visual field, and an examination of the fundus, the optic nerve appearance. So there are lots of other tools in our armamentarium. OCT is there everywhere. You take from ophthalmology to neurology, everywhere people talk on OCT. So OCT is going to show the structural changes. And then comes the neuroimaging of brain and orbit. always ask for brain and orbit, because you may miss some lesions in the way, in the orbital apex, in the superior orbital fissure. When you get up lesions in that position, you may miss the lesion if you get only a MRI brain and you do not get that of the orbit. So this is the type of lesions you can see. You can read it up in the textbook. Again, any LGB beyond lesions, your pupillary reactions will be normal. So don't get carried away with that. So let me go case-based. This is a 30-year-old female with a complaints of sudden painful drop in vision over a week duration. She had right eye grossly normal, left eye had a 2-meter vision with a relative afferent defect. So where do you think the lesion is going to? Just rattle, whatever you feel like. Shoot. What's the next thing you are going to see now? Fundus. See the fundus. So now you know what it is. Where is the lesion? Cortex? It's in the optic nerve. So what is the next investigation you're going to plan? We know like what type of optic nerve functions we are going to do. So what is the next investigation? Color is dropped, I have told. So what is the next? That's the last. Before that, don't give money to the radiologist. You do first. What's in your clinic? Perimetry. Yes, excellent. Perimetry. Do a perimetry first. So the right perimetry is normal and that of the left is washed off. Okay, that also the patient got it earlier. And don't think you need always an automated perimeter to get that. A simple confrontation test is also going to be very useful for you to pick the disease. So what do you see? Now we have the glorified MRI over there. You see a lot of black and white stuff over there. And what you have, the problem is in this region. You could see this is the axial, fat suppressed T1 flare images where you can see a grossly thickened optic nerve. So this is the condition what we are dealing with. So what we are dealing here is a optic neuritis. And to add more flavors to this, we have a lot of seromarkers which are coming up in the literature. So be very careful what type of optic neuritis it is. So you may have to get, according to the ONTT, you don't need that much of blood test. But if you suspect a atypical neuritis, you may have to do a lot of blood tests, because still this type of disease are evolving in this part of the world. And that's the Mog spectrum disorder optic neuritis, what you're seeing over here, because they have some characteristic features which you can read in the literature. So this patient was treated with IV steroids and she recovered well. So this is a 37-year-old female, again with a history of drop in vision in the right eye, and now she had low-grade fever and headache. And the right eye is again having a moderate drop in vision. There's a relative afferent defect, color vision is dropped down, and the left eye is normal by all means. Do you think any other further history I have to ask in this patient? Sorry? Brilliant. Neck rigidity. Yes, exactly. And I'm going to give one more clue to you. The patient had, and she is living with her brother who is having a TB. So in our part of the world, be always careful. We have a lot of infective spectrum overlay, because you're going to pump them with high-dose steroids, chronic immunosuppression. And this lady, she had, this is her fundus appearance. So she had a gross optic nerve swelling, and that's a perimeter showing a dense inferior field loss. SSOCT is showing a gross elevation. That's a granulomatous lesion over there. And that's the MRI. Here again the lesion is in the optic nerve, but here as you could see, it is not sticking only to the diffuse thickening of the optic nerve, it's more of a sheath enhancement. Here the disease is predominantly in the optic nerve sheath, which is very characteristic for a perineuritis, a granulomatous type of picture, which can be easily misdiagnosed as a Mog disease too. So go on with the blood investigations, and with the systemic history, we may have to add up other investigations also. So she was positive for Manto and gene expert, and her chest showed a lot of nodes. So she was put on antituberculous treatment along with steroids, and that's the results what you see down the line. So she improved in her visual field as well as in her color vision, and a good recovery of the fields also. So that's a granulomatous optic neuropathy secondary to TB. So we saw a lot of cases from our previous speaker. So this is a lady who was referred to us with complaints of painful double vision. So here it was painful double vision to start with, but in the meanwhile she started having a drop in vision also for 10 days. and her right eye vision was 6/9 and that of the left eye was 6/12. So what do you think this lady can have? Where is the lesion? So what are the potential differentials you would give up? Remember, she came with pain and this picture. Okay. Commoner. You saw lots of images from the previous speaker. Yes. Good. Thyroid is a good differential. What else? Red eye. So much of engorgement. All movements restricted. Pain. Very good. There could be a cavernous sinus pathology. So, thyroid profile normal, all the other evaluations were normal. I think it's not moving. Is some problem? Okay, got it. So this is the fundus what you see in her. So do you think still the lesion is in the optic nerve? Visual fields are normal. And now you go, this is the orbit, MRI. So you see significant thickening of the extraocular muscles, but it is not sparing the tendon like what you expect in a thyroid. It's also extending to the orbital apex. So you see a orbital apex crowding, that's a bilateral compression, and you see grossly thickened extraocular muscles. So this working diagnosis were there for us, IOID, myositis, TED, IgG4 disease. Her anti-TPO was slightly elevated. We got all the specialties into the loop. We put her on IV steroids followed by oral steroids, but we went ahead and did a muscle biopsy too, which revealed diffuse inflammatory reaction, and that was a sarcoid-related inflammatory myositis, what we saw, and she had a very effective recovery post-steroids, and that's a picture. There's a good resolution of all the soft tissue, and the vision also got better. So next, moving on to the chiasm, unexplained vision loss and a headache. Be very, very careful in such patients. They may come to you with 6/6 vision. All the optic nerve function test, what you see and talk may be normal, but always check for the visual fields, because early fields will start in a chiasmal syndrome, which will give you a clue to image these patients. Very, very few times, like you will see patients who are having raised ICP also with a chiasmal syndrome. That can happen when your chiasmal lesion is going to pump up and move on to the suprasellar segment, where it can compress the third ventricle and result in that particular presentation. So signs of chiasmal syndrome can be optic neuropathy, and the optic disc changes can vary from normal to temporal pallor to bow tie or band, and a papilledema will happen, as I mentioned, in suprasellar involvement, and the other features are seesaw, and if it is going to involve the parasellar segment, we are going to have syndromes of the cavernous sinus involvement also. So this is a guy who presented to us with a drop in vision for 4 years, and he had a road traffic accident 4 years back. So after that, which he vision dropped in the left eye, and you can see definitely he has a lot of facial asymmetry in the left side. His vision in the left side was 3/60, and there was a relative afferent defect, and the CT had multiple orbital fractures. So this is a visual field what you see, and that's the optic nerve head what you see as a photograph. Could you see something which is not very, very typical for this in the optic nerve appearance? For a 4-year-old vision drop, what should you see in the optic nerve? Pallor. But do you see an optic nerve pallor in that left eye? That's the first clue you have to pick. And you see the visual field, it's densely wiped off in the temporal segment. And that of the right also, you can see the superotemporal peripheral area showing some changes. So this patient, he had a CT orbit. Unfortunately, they did not escalate it cuts to the brain, and which we repeated on an MRI, had a significant cellular mass, which was the cause for the vision drop. So what you saw in that patient, he had a combination of causes. He had a road traffic accident, presumed to be a traumatic neuropathy, but his vision and optic nerve and fields were not going hand in hand. So that makes you clue to go ahead and probe on your neuroimaging, and you have to ask for more further neuroimaging and always prefer an MRI brain and orbit, because many times we may not get a proper adequate cuts. And that's a lesion, and this is post-surgery. The same patient improved, and complete recovery of the visual fields. So this is a 41-year-old female. She was referred to us as a thyroid eye disease. She had ptosis, she had squint for 2 years with lid signs. So I'll see how you guys are picking up the lid signs. There's a drop in the right eye vision and that of the left eye is normal. So is that the buzzer for me? No? Yes? Okay, what do you see here? 5 minutes, done. Okay, what do you see here? Quick. Is there something you see in the central photograph? Oh. Right, mild droop. In this side photograph, what do you see? What do you see here? The bell is going to go up. There's an adduction restriction, okay? And what do you see here? It's full. There's an elevation restriction over here. So there's a right side vision drop and her adduction is restricted and you could see, what do you see here? Single clue. That's a right third nerve with aberrant third nerve regeneration. You see an inverse Duane's and a pseudo 1 graphe, okay? There's a right side drop in vision. This lady is not having TED. So that's her fields. So that's a dense field loss, and again there's a sella mass which has to be operated. She had a multiple cranial nerve involvement and the lid signs were mistaken for thyroid eye disease. So, and post-surgery she had a good visual recovery. And retrochiasmal lesions, you have to always look in for incongruity of the hemianopia. If it is more incongruous, it is going to be anterior. A more posterior lesion is going to have a congruous defect. And this you can see only in incomplete hemianopias and not in complete hemianopias. So let me skip this theory. Okay, this is a guy who was brought to us with 6/6 vision. He had repeated falls. His wife told that he is driving in one direction and I'm scared to sit next to this guy. So this is the visual field. What type of fields you are seeing over here? Dr. Chandrima is not going to give me 2 more minutes. You better say. What type of fields is this? You see only in one particular quadrant, it's only inferior defects, okay? So you see only in the right side inferior quadrant. So that's a right pie in the floor defects, what you're seeing. And correspondingly, this guy is having a huge lesion in the left side parieto-occipital region with a cerebral bleed. And this, okay, let me skip and I'll give you a, this patient is very common in all your day-to-day practice. An elderly gentleman brought by the son saying that having cataract, get him operated, and he's bumping into objects. His cataract is not matching with the visual acuity loss. So first thing you have to check, he's got a bilateral PL vision, fundus normal, VEP very mild delay in latency. You're not able to explain the vision. Do not think anything, go ahead, image him. That's a cortical visual drop. If you're going to operate such cataracts, you're going to have a very bad prognosis. So always explain, find out whether the cataract is matching to the vision loss, then proceed with your cataract surgery. So that's a cortical visual impairment. So I think I may not have time to cover for a diplopia. So let me move on to the last slide. So detailed history taking is very important in neuro-ophthalmology. Associated signs and symptoms like headache, ICP features, type of field loss, concentrate on that particular history also. Correlate the vision to the clinical features. Differentiate retinal versus optic neuropathy and ask for MRI brain and orbit as and when required, because sometimes you will have incidentaloma and you may have some other ophthalmic disease. So always correlate the vision loss. Let me take this opportunity to invite you all for the 6th annual Indian Neuro-Ophthalmology Society meeting, which is going to be held at Shankar Netralaya, and we have a huge galaxy of international neuro-ophthalmology speakers visiting us. Hope to see you all in Chennai. Thank you.